Okay, recording is started.
Perfect. All right. Thank you. Hopefully everyone's had a chance to review those meeting minutes from November. We'll be looking for a motion to approve those from.
I noticed one minor error. There's some references to P&T board. Technically, this body is a subcommittee of the DUR board, so it's the P&T committee. And so I was that we make that change and correction on the minutes.
I'll second that motion. Make that change and then approve once that change is made. Is that the?
Yep.
Perfect. All in favor, say aye.
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 All opposed? And any abstentions?
I'll abstain just because I was absent last meeting.
Weren't there. Absolutely. Thanks, Clayton. All right. The motion carries. And now next, was there any housekeeping, Brian?
The only housekeeping item I have is to announce we have a new pharmacy director. Yoon, I'll let you take care of that.
Yes, thank you so much, Brian. Sorry, I am just getting on. Thanks everybody for being here. We do have a new pharmacy director. She literally just started. Her name is Sapide Dari, and we're excited to have her join us. And I'm actually going to just let her introduce herself and tell us a little bit about herself and her background. If she's here, Sapide. Okay, well, I can go.
No, can you
Oh,
hear
there
me?
she is. Yes, there she is. Okay.
Little bit of difficulties of like unmuting myself. Good morning, all. My name is Sapide Dairi. Today is, I think, my third day starting working as the pharmacy director with Medicaid, and I'm really excited. I worked as a market director over pharmacy, healthcare, including optical with Walmart for over 10 years. I worked as a pharmacy manager since 2009. So my background is I have a doctor of pharmacy degree with Roseman. So I worked for Walmart for almost 18 years. I have different backgrounds. I'm originally from Iran. I have bachelor degrees with software engineer, and for a few years, and I decided I'll go for the healthcare degree. I have 2 kids, and I've been in Utah over 26 years.
Awesome. Thank you.
Thank you.
Thanks, Brian. We'll let you go ahead and continue on with your agenda. Thanks, everybody.
Absolutely. Thank you for that introduction and welcome. Our next agenda item today is Dr. Nguyen will be giving us a DUR board update.
Good morning, everyone. So in December, the DUR board has reviewed antidepressants insurance. And in January, the board has reviewed Lantudra and approved the proposed Lantudra PA. And last month, the DUR board has reviewed the utilizations and adherence rate for Sublocade injections in Medicaid patients. And we are working on policies or looking to improve the adherence in Sublocade patients and Sublocade and Medicaid patients.
Great. Thank you very much for that update. Moving along in our agenda, we have Dr. Gonzalez reviewing the anti-VEGF.
All right. Do you see my slideshow there?
Yep.
See. Okay, so today we're reviewing the intravenous anti-VEGF agents for approved oncologic disorders. Let's see if I can. To move forward there. Okay. Intravenous vascular endothelial growth factor inhibitors, abbreviated IV anti-VEGFs, include bevacizumab, 4 bevacizumab biosimilars, ramucirumab, and ziv-aflibercept. Anti-VEGF therapies inhibit either extracellular VEGF receptors on endothelial cells or certain VEGF ligands. Ultimately, they downregulate the pathway that stimulates angiogenesis and progression of certain cancers. Altogether, approved indications of IV VEGF therapies encompass many oncologic disorders, including metastatic colorectal cancer, advanced hepatocellular carcinoma, non-small cell lung cancer or NSCLC, cervical cancer, ovarian, fallopian tube, or primary peritoneal cancer, recurrent glioblastoma, metastatic renal cell carcinoma, and gastric or esophagogastric cancer. Bevacizumab has the most approved indications, and its 4 biosimilars have most of the originator's indications, with the exception of hepatocellular carcinoma. There are 4 indicated diseases unique to bevacizumab. Ramucirumab has 4 indicated diseases. It's the only IV anti-VEGF with indications for gastric and esophageal junction cancers. Ziv-aflibercept has only 1 indication for colorectal cancer. Across these agents, there are 3 FDA-indicated disease states in common, which are colorectal cancer, hepatocellular carcinoma, and NSCLC. However, since approved indications are also specific to use as first or second line therapy, prior failed treatment, or other clinical characteristics such as genetic mutations or histologic features, indications may not fully overlap. For metastatic colorectal cancer, bevacizumab and its biosimilars are approved for first line or for second line systemic therapy, whereas ramucirumab and ziv-aflibercept are approved only for subsequent line therapy after failing particular prior treatments. For hepatocellular carcinoma, bevacizumab in combination with atezolizumab is approved for first-line therapy of advanced disease, whereas ramucirumab is approved for subsequent therapy in patients with prior failure on sorafenib. Patients must also meet the indicated alpha fetoprotein level for ramucirumab therapy. In the setting of advanced NSCLC, bevacizumab and ramucirumab are approved for first-line systemic therapy. However, bevacizumab is indicated only for non-squamous histology, while ramucirumab is indicated only in the presence of certain genetic mutations. Additionally, ramucirumab is indicated for subsequent therapy. Regarding NCCN treatment guidelines, there are 3 cancer categories for which multiple IV anti-VEGFs have a recommended place in therapy. Those are metastatic colorectal cancer, hepatocellular carcinoma, and NSCLC, which these are consistent to the overlapping approved indicated areas. In the NCCN guidelines, wherever bevacizumab is recommended, the panel also considers the approved biosimilars as acceptable alternatives to the originator. For metastatic colorectal cancer, bevacizumab-based therapy is recommended in first-line and subsequent line regimens. Ramucirumab and ziv-aflibercept are recommended for certain subsequent line scenarios as well. But in subsequent line scenarios where the 3 IV anti-VEGF agents are options, the NCCN preference is given to bevacizumab over ramucirumab or ziv-aflibercept due to toxicity and or cost considerations. For hepatocellular carcinoma, bevacizumab with atezolizumab is approved for first line, is the preferred first line regimen, whereas ramucirumab is among subsequent line regimens. For advanced metastatic NSCLC, bevacizumab and ramucirumab have both overlapping and unique places in therapy. and the guideline does not specify a preference or one over the other in the indicated areas of overlap. Bevacizumab or ramucirumab, each combined with erlotinib, are recommended as first-line regimens for EGFR mutation-positive disease. However, bevacizumab is recommended only for non-squamous histology, whereas ramucirumab may be used for either non-squamous or squamous histology. Many bevacizumab-based regimens are recommended as first-line therapy for non-squamous NSCLC without actionable driver mutations, whereas ramucirumab is a subsequent line recommended therapy in this clinical scenario. Slide shows the cancers for which only one IV anti-VEGF is NCCN recommended for the disorder. Bevacizumab has a recommended place in therapy for metastatic renal cell carcinoma, progressive high-grade gliomas, metastatic cervical cancer, and epithelial, ovarian, fallopian tube, or primary peritoneal cancer. Ramucirumab has an NCCN recommended place in therapy for advanced or recurrent gastric, esophageal, or gastroesophageal junction adenocarcinomas. So based on our literature search, systematic reviews show that there are no head-to-head comparative RCTs available for these reviewed therapies within their overlapping disease areas of approval. This finding is consistent with clinical guidelines, which also do not show comparative studies between the IV anti-VEGFs. This is likely because these agents were either used in different lines of therapy or were compared to other therapies that were the standard of care at that time. On the other hand, a few comparative RCTs were identified for bevacizumab biosimilars compared to the originator. No notable safety or efficacy differences were found between the originator and biosimilars based on meta-analyses or individual RCT data for outcomes of interest such as objective response, progression-free survival, or adverse events. This finding is in line with the FDA definition of a biosimilar as having no clinically meaningful differences in terms of safety, purity, and potency compared to the reference products. Table 18 of the report summarized recognized off-label uses among Micromedics and Lexicomp drug information compendia. Bevacizumab has many off-label uses, categorizes by Micromedics as effective or evidence favors efficacy, and several bevacizumab off-label indications are noted by Lexicomp as guideline recommended. Let's see, okay. Such as for the treatment of age-related macular degeneration and diabetic macular edema, among others. Among the compendia, only one off-label use is listed for ramucirumab or ziv-aflibercept. IV anti-VEGF therapies share many warnings in common. As a class, they impair wound healing and may be associated with a small elevated risk of hemorrhage, GI perforation, thromboembolic events, hypertension, proteinuria, and a neurologic disorder called posterior reversible encephalopathy syndrome. A warning regarding infusion reactions, some potentially severe, is labeled for bevacizumab and ramucirumab. So patients should be receiving these medications in a healthcare setting to closely monitor for hypersensitivity immediately following their administration. Additionally, pre-medication is required with ramucirumab. While neutropenia is a warning only for ziv-aflibercept, it was reported as a common adverse event for each anti-VEGF for at least one indication. So overall, considering the wider range of approved disease states for bevacizumab compared to ramucirumab and ziv-aflibercept, In addition to its many recognized off-label uses among the drug compendia, a bevacizumab-based IV anti-VEGF formulation, either originator bevacizumab or an FDA-approved biosimilar, may be considered for preference on the Utah Medicaid preferred drug list. An FDA-approved biosimilar is considered an acceptable substitute by the NCCN guidelines for originator bevacizumab for applicable reviewed indications. Non-preferred products can be made available by prior authorization, especially to consider and accommodate clinical scenarios for which bevacizumab is not approved nor guideline recommended, or for scenarios where guidelines recommend bevacizumab secondarily to another IV anti-VEGF therapy. And that's all I have today. Let me know if you have any questions.
Thank you very much for that thorough review, Dr. Gonzalez. We'll move on to public comment, but I didn't see any on the agenda. So we'll move on to committee discussion. I think here, as we're looking for inclusion on the PDL, the preferred drug list there, I think we all want access to these medications when appropriate for the appropriate indications. I'm not certain how granular to get with that, Brian. Like for example, gastric or esophagogastric cancers, like for ramucirumab over bevacizumab.
The way our prior authorization is structured is essentially we require either an FDA approved indication or a compendia recommended indication, but it's pretty broad. And what we've done in the past with some other drug classes is we've tried to have at least one preferred agent for every indication within the class. And so in some cases there's drugs with broad indications that might be preferred, and in other cases there needs to be a variety of medications, and obviously we would take costs into account as well.
Great. Yeah. Thank you for that background. And do we have any utilization data over the years?
Yeah, do you want me to pull that up, Brian?
That would be great. Thank you, Val.
Pull that up on my end here. Okay, can you see that all right? So we looked for bevacizumab, ramucirumab, and zivalflibercept claims from 2021 to 2023, and we didn't find any zivalflibercept claims. This is what we have for bevacizumab and ramucirumab. So you can see most recently, 2023, how many bevacizumab claims we have, and then patients, and then hardly any for ramucirumab. And then I also explored what ICD-10 codes were associated with the claim that were found within 45 days prior to this claim or up to 5 days after. So the ramucirumab patients, and I looked just at the 2023 claims, the ramucirumab patients, they had claims that are suggesting that they're using it for the approved indication. And then the bevacizumab claims, I kind of broke down ICD-10 codes. I looked at codes that are closest to the approved indication. So the patient totals are pretty low compared to, the 400 total we have. Like there's 14 that look like they are using it for colorectal cancer, about 15 or less for liver cancer. And then I think there's fewer in each of the other categories. But we did, let me see if I get it to, we did also update the ocular disorders that we presented on last time, and we showed you bevacizumab claims, but at that time there was a glitch in the database and we weren't able to pull all 2023 claims. So that was fixed and we were able to consolidate all those claims. So you can see this is the amount of patients. Sorry, I don't have that header there, but 123 patients have these ICD-10 off-label ocular disorder indications. So it's looking like the majority are using it. Well, a lot are using it for ocular, and then there's probably a whole lot of other off-label use indications that that my list didn't capture there. That might make up the rest. So hopefully that gives you a better idea as far as, between each of those three main products, what the breakdown is.
Perfect. Yeah, no, thank you for that. And I know for the IV anti-VEGF, they'll dose it every 2 to 3 weeks pretty routinely. That's kind of the general range. So yeah, that top of the 45-day look back should be capturing pretty much all of those. And some of the ocular indications go with the larger frequency. So, prolonged once every 3 months, give or take. So that's great. No, thank you for that data there. If there are any thoughts from the committee, we'd love to hear those now. Great. So looking at this, it does, especially with the utilization data, bevacizumab inclusion on the PDL seems appropriate. So if I could get your assistance in forming a motion here, let's say the PDL should include at least one FDA approved or NCCN guideline recommended therapy for the various indications. And
So typically we go with compendia recommendations
Yeah.
in our PDL, which would be micromedics essentially. But I think it's probably, Val, correct me if I'm wrong, but I think the compendia recommendations are consistent or somewhat aligned with NCCN guidelines.
Yeah, as far as the approved indications that I reviewed, yeah.
that's good. I like defaulting to compendia as that will be the most up to date and should encompass NCCN. So that sounds great. Thank you, Brian. I'm trying to capture all of the indications in there too, and maybe that's where I'm getting held up making the motion.
Well, I think if we, rather than try and list them out, because in the future there could be new indications that we're not aware of now. And so if we use as our guidance FDA and compendia recommended indications, or even FDA approved indications, and then when we're doing coverage, authorizing a prior authorization, we would also look at those compendia. But I think for the purpose of the PDL, I think we're okay with saying, agents FDA approved for those indications.
And you would say FDA approved over NCCN recommended, or I just didn't want to. It's those they usually don't go back and get new approval once it.
Right. When we're doing a prior authorization, yeah, we would look at those broader indications.
I will just mention that once in a while, I did see maybe something in the NCCN guideline that wasn't exactly replicated in the compendia. And
Mhm.
that is, I summarized some of those observations in the off-label use area. And that might be where, like, it says bevacizumab, is approved for first line therapy, but then maybe it's used for subsequent line therapy, and that's also recognized in the NCCN guidelines, or there may be certain combination regimens where some are being used and the NCCN recommended, and you might not see that in micromedics, maybe because it's like based off a really new study. So I don't know if there's lag time between micromedics and NCCN guidelines, but those NCCN guidelines, like they're updated for some of those disorders like 3 or 4 times in a year. So I can imagine sometimes it can be hard for the compendia to keep up with that.
Yeah, I'm amenable
Go ahead,
to.
Brian.
I would be amenable to deferring to NCCN if the committee feels like that would be more appropriate.
I found it to be. I'm not an oncology pharmacist, but I found it to be pretty accurate and updated very quickly. So I would feel comfortable with that organization.
Yeah, and we've used NCCN guidelines for antiemetics as well.
Great. So the motion here, and please help me out. PDL should include at least one NCCN guideline recommended anti-VEGF medication
As preferred.
as preferred on the PDL.
Okay.
I would second that.
Thank you. And all in favor?
I
Aye.
All opposed? And any abstentions? All right, the motion carries. And I don't feel the need to vote on the prior authorization process, or we typically do not, but looking at the utilization data, patients are able to obtain other medications when those situations arise. So that process has worked well with other meds and other indications, but I just want to make sure the committee feels comfortable with that for those situations, perhaps where a different anti-VEGF is preferred.
Yeah, I mean, if the only drug approved for a particular indication is a non-preferred drug, typically the approval is not going to be very difficult.
Great. Any other items of discussion or any other motions anyone wanted to make here? Thank you all very much for attending. I'll make a motion to adjourn.
I'll second that.
All in favor?
Aye.
I
All opposed? And any abstentions? The motion carries. See everyone in May.
All right.
Aye.
Thanks,
Thank you.
everyone.
Thank you.
Thank you. Thanks, everybody.